Good evening and welcome to Doctors on Call. Tonight we're talking about upper GI problems, from ulcers, gallstones, and hepatitis to heartburn and indigestion. I'm Dr. Alan Johns from the Department of Family Medicine and Community Health at the University of Minnesota Medical School Duluth, and I'll be your host this evening. What would you like to know about stomach and digestion issues? We're ready to take your questions. Give us a call locally at 218-788-2844 or toll free at 1-877-307-8762. I'm pleased to welcome our panelists this evening. Dr. Thomas Malloy, a gastroenterologist with Essentia Health Duluth Clinic. Dr. Daniel McKee, a gastroenterologist with Northland Gastroenterology Associates. And Dr. Tom Nelson, a general colorectal surgeon with Mercy Hospital in Moose Lake. And we have some of our medical students answering phones tonight. Stephen Palmquist from Becker, Shrikar Rajgopal from La Crescent, Minnesota, and Ben Stranghelli from Lindstrom, Minnesota. And now on to tonight's program on upper GI problems. Well, Dr. Malloy, you know, a common complaint I hear from patients all the time is heartburn or reflux, or is there seem to be a lot of that now, or is it just that we're asking more about it?
I think there's more of a perception amongst people and through the media as far as heartburn, and a lot of advertising of medications that are available, and so I think people may be more aware of this, and in the past where they've looked at symptoms and maybe disregarded them or put up with them or used baking soda or something like that, now there's a readiness to try and get it fixed. There are a lot of medications available now and a lot of options that are available.
And I might just add, I think there is more reflux. I think you're right, there's more of an awareness, but I think there's so much of a relationship between obesity and reflux that with the unfortunate obesity epidemic in America, that there is more reflux. There just is more of it, unfortunately, than there was even 10 or 15 years ago.
Well, Dr. McKee, at sometimes I have patients get endoscopy done where the gastroenterologist will look down there. When do you do that? Is that something that people should have regularly, or is it just something, a certain length of symptoms, or what makes you decide to do that?
Well, there are a lot of reasons why you would do an endoscopy, but with respect to reflux, certainly not everyone who has heartburn or reflux symptoms needs an endoscopy. I think it becomes important when someone's had reflux symptoms for a very long time. Then we are interested in looking for a condition that may have developed called Barretts, which is a condition which increases one's risk for cancer. But someone who has occasional reflux, occasional heartburn, or maybe has had symptoms for a relatively short period of time certainly doesn't need an endoscopy. The other time when it would become important is when there are symptoms other than just plain garden variety heartburn or reflux, but so-called red flag symptoms such as trouble swallowing, food sticking, something like that, or weight loss, something that would make us concerned about something more than just routine reflux, but maybe something more serious.
Sure. And Dr. Nelson, speaking of reflux, does people still have surgery for that occasionally?
Yes, there's a variety of alternative treatments. There's endoscopic treatments. There's certain gizmos, so to speak, that they can put on scopes, or scopes are made to do certain things within the stomach to help prevent reflux. And there's also radiofrequency ablation, the Stretta procedure. Then there's this magnetic bracelet that's come out now called the Lynx, and it can be put in laparoscopically. It's like a collar, a magnetic bracelet around the lower esophageal sphincter that helps keep that closed so acid can't go up and down.
Interesting.
But the magnets are weak enough so it'll open as the patient swallows.
Huh.
And then the probably the standard right now would be the laparoscopic Nissen fundoplication, where we actually wrap the upper part of the stomach around the esophagus to reinforce that valve there that people talk about so that things don't wash up and down.
Thank you. Dr. Malloy, there's a question, a caller from Two Harbors would like to know, why does food get stuck in her esophagus? Is it a problem that she's not chewing enough, or are there other causes?
Not necessarily. I think there are a number of causes that need to be looked at with that sort of problem, one of which we've touched on already in terms of reflux. There can be complications related to reflux where there's scarring, narrowing of the esophagus, and that can certainly lead to food hanging up. It's also important, of course, to evaluate to make sure that there's not another cause for narrowing, especially malignancies and esophageal cancers. Other potential benign causes, motility or contraction issues, can cause some chronic problems. I guess I would be most worried in the situation where it's a new finding or it's a progressive finding, and associated, Dr. McKee's already talked about red flag type symptoms. Association with weight loss would also be something that we'd be concerned about.
Thank you.
I'd like to add that there's a somewhat new entity called eosinophilic esophagitis, where it's an immunologic reaction to a certain food, and you get an inflammatory response in the esophagus, and your esophagus doesn't work very well, and that causes dysphagia, and that's where you can't swallow your food and it gets stuck. I just had a patient yesterday and a patient today that had the classic signs of that and symptoms, and actually had a weight loss and real problems swallowing. That's something that needs to be taken into account as well, and you have to do biopsies to make that diagnosis.
Dr. McKee, you mentioned Barrett's esophagus. We have two callers here, both from Duluth, who want to know about Barrett's esophagus. One wanting to know, is that something that there's certain foods you should avoid? And the other one question regarding how often you should have an endoscopy if you have Barrett's esophagus.
Well, as far as foods to avoid, really, yes and no. If you have Barrett's, avoiding certain foods isn't going to... The issue, again, with Barrett's is that it's a change in the lining of the esophagus as a complication from long-standing acid reflux, and we're concerned about it because it increases the risk of developing a certain type of esophageal cancer called adenocarcinoma. Avoiding certain foods isn't going to reduce your risk of developing cancer, so if you have it, being on a certain diet per se isn't going to change that risk. Now, avoiding certain foods will reduce your degree of acid reflux, so to the extent that avoiding the foods that make reflux worse is helpful. But as far as the cancer issue, which is the important thing, it's not going to change things. In terms of how often to get an endoscopy, if you have plain garden variety Barrett's, the answer is every 3 years. When we do biopsies of Barrett's, what we're looking for is to see if there's any progression towards cancer, and the term for that progression is dysplasia. If the Barrett's has progressed on the continuum from Barrett's to cancer and has developed dysplasia, then the screening interval shortens, and how much shorter that interval depends on the degree of dysplasia. And I think going into that is maybe beyond where we want to go tonight.
Certainly. So 3 years or maybe more often, depending.
Depending, but 3 years would be the longest you would wait.
Well, thank you. Dr. Nelson, a caller from Virginia. This is a common question. What is a hiatal hernia? Everybody talks about hiatal hernias, but what is it?
Hiatal hernia is where a part of your stomach will go above the diaphragm. So your diaphragm has an opening where the esophagus, so if my thumb is the esophagus and my hand and palm is the stomach comes up through that opening a little bit, or sometimes the entire stomach gets up into the chest, and that's called a paraesophageal hernia. Your garden variety hiatal hernia, a lot of people have. You don't need an operation. Sometimes it can contribute to reflux problems because there's usually 5 factors that focus right in at the lower esophageal sphincter to keep that closed, like an iris valve. And when the hiatal hernia is present, it kind of pulls those all out of focusing at one point, and they're more in sequence and all at one point, so it predisposes people to reflux.
Thank you. Dr. Malloy, a caller from Duluth would like to know about taking corticosteroids. Does that cause dysphagia? Or maybe we should just widen the question and say, does corticosteroids, does that irritate the stomach other ways?
To answer the question in regards to the esophagus, there are situations where corticosteroids could impact by leading to an infection in the esophagus. And that's true of not just oral corticosteroids such as prednisone, but also inhaled steroids. And they can predispose to a fungal infection, and oftentimes the symptoms associated with that are trouble with swallowing, either food sticking or pain. As far as the stomach goes, there's been discussion, especially in old literature, in terms of steroids and their effect in causing ulcer disease. These days, I think we're more aware of other medications potentially being a bigger cause as far as ulcers go, and not so much with corticosteroids.
What kind of other medicines?
Well, anti-inflammatory medicines in general. A couple of categories. One would be aspirin. The other would be the non-steroidal anti-inflammatory medications.
Thank you. Dr. McKee, we have a caller from Cloquet wondering about pancreatic cancer, about possible causes, and is there anything new as far as research in curing pancreatic cancer?
Well, pancreatic cancer is a horrible cancer. It still has a really poor prognosis. In terms of causes, there's an association between cigarette smoking, between alcohol use, especially alcohol abuse. There are certain hereditary types of pancreatic cancer, so there's certain gene defects that predispose to pancreatic cancer. So there are certain familial types which are relatively uncommon, but certainly well described.
Anything new in the treatment field?
I don't think there's anything particularly promising in terms of treatment right now.
I think the biggest thing that may be new is our ability to diagnose it and what we have available.
Diagnose it earlier, you mean?
Well, hopefully. I think the same problem is there that has always been there, in that oftentimes pancreatic cancer won't give early symptoms. And I think that's still the case. We do have more things in our armamentarium as far as evaluation and biopsy and things like that. But I think the challenge remains detecting it at an early stage when it's potentially curable.
Thank you. Dr. Nelson, we have a caller from the Iron Range wondering about, can severe bloating cause gallbladder disease? Or maybe you could almost flip that around. What are the symptoms of gallbladder disease?
Yeah, bloating itself cannot cause gallbladder disease, and usually gallbladder disease doesn't cause bloating. It's more of a sensation of pressure within the gallbladder that gives that sensation of being bloated visibly. Mainly gallstones cause the acute onset or sudden onset of rather severe right subcostal pain, maybe in the upper stomach, goes to the back or between the shoulder blades, lasts for minutes to a couple hours, and then it's gone. And then it can be a variable amount of time, and then they have another attack. That's classic gallbladder disease, what we call biliary colic.
Can people have gallstones and not have any symptoms?
Oh, definitely. They can have an ultrasound or a CT for another reason, and it shows up the gallstones. And you really don't need them taken out or have the gallbladder with the stones removed unless you're having symptoms, or you're in a special subset of patients such as women of childbearing age, because you don't want to have a gallbladder attack while you're pregnant, or maybe someone who's going to be away from urgent medical care, like if they're out doing mission work or fishing out on the seas, that type of thing.
Okay. Dr. Malloy, we have a caller here wondering about H. pylori. How to get rid of it, or are you stuck with it?
Well, no, you're definitely not stuck with it. H. pylori is a bacteria that's ingested at some point in life commonly through food. It's a very common organism, but it can cause gastritis or inflammation of the stomach as well as ulcer disease. It is diagnosed in a number of fashions. There are blood tests that can be done to look for antibodies to the bacteria. There are stool and breath tests, and then there's endoscopy, and all of these modalities have potential for diagnosis. We do have a number of medications we can use. The typical regimens combine stomach medicine along with 2 different types of antibiotics for a period of 2 weeks. And those regimens are potentially 85 to 90% successful.
Thank you. Dr. McKee, this also goes to GERD. A lot of questions about that. A caller from Duluth would like to know, how long can someone with GERD take omeprazole? Her husband's been taking it for 14 years.
Well, there really isn't a limit. You can take omeprazole, or omeprazole is a proton pump inhibitor, and there are several others, and there isn't a limit to how long you can take a proton pump inhibitor. There are some concerns about long-term use of proton pump inhibitors. I think as far as prescription medicines go, they're really quite safe, but small risk of certain kinds of infections by eliminating the acid barrier in the stomach, which helps to protect against certain types of bacterial infections, and some impairment of absorption of calcium and magnesium. So there are some issues with long-term use of proton pump inhibitors like omeprazole, but there's no contraindication necessarily to using them lifelong.
Overall, they're pretty safe. I mean, they sell them over the counter.
Yep, absolutely.
So.
Yeah.
One of the things I like to add is the timing of taking a medication. A lot of people think they can just take it as needed, or they take it with meals or after meals. So you should take it about a half hour before meals to get the best bang for the buck, so to speak, so it works the best for people.
Well, thank you. Dr. Malloy, there's a caller from Duluth, and this is an interesting question, and I'll certainly pose it to anyone here. But you first, this patient has had a diagnosis of H. pylori and an ulcer. When she goes for a run, she gets esophagus discomfort. Why does this happen?
Well, there may not be an association between an H. pylori related ulcer and her symptoms. There are a number of potential causes for esophageal pain. Some would involve reflux. There's also other potential causes such as esophageal spasm, which can cause chest pain. The association with those symptoms in an H. pylori related ulcer probably are not there. That's more of a stomach sort of issue.
I guess I would wonder about any exercise-related chest
cardiac.
discomfort. Do you want to make sure that you don't have a heart issue
Yeah,
going
absolutely.
on? So
That's probably the most important.
probably talk to her physician and make sure her heart's okay.
Yep, absolutely.
Okay, thank you. Dr. McKee, a caller from Duluth was recently diagnosed with celiac disease. She says she doesn't have symptoms, but will cutting out gluten get rid of her villous atrophy? So do I need to cut out all gluten, even if it doesn't make me feel sick? It's a little hard. That's kind of a hard question, but maybe we can rephrase it and say, if you have celiac disease, do you have to really stay away from all gluten?
Well, if you have celiac disease and you're going to treat it, you really need to avoid gluten. It is a complicated question. I think the issue here is she doesn't have symptoms. She was found somehow to have celiac disease, and do people who don't have symptoms but have celiac disease need to be treated? And that is debatable. She won't feel better if she's treated, and being on a gluten-free diet is actually very difficult to do well. So it's a big lifestyle change for her. It's a big sacrifice, and the only advantage is there is a relatively small risk of small bowel cancer with celiac disease, and the risk goes down if you're on a gluten-free diet. So the advantage to her, even though she doesn't have symptoms, is she may be able to reduce her risk of malignancy. But she is going, and to do that, she needs to get rid of that villous atrophy and reduce the inflammation from the celiac disease. But the trade-off is to really do that diet is very, very strict adherence to avoiding gluten, and that is a lot of work.
Mm-hmm.
It's a lot more than just not eating wheat bread, and so that's something she'll have to decide for herself.
Sure.
The other thing is she could develop iron deficiency anemia from not absorbing the iron in the duodenum where this mostly occurs. And that's something that can sneak up through the years, and then she'll be feeling tired, and that would be another beneficial reason to stay on the gluten-free diet.
Well, thank you. Dr. Nelson, here's this a question that we approached a little bit, but it's an interesting question. A caller from Woodson wanting to know, why is pancreatic cancer so prevalent today, or is it more prevalent than it used to be?
I don't know much about that. And you guys have any info on that?
I don't think it's more prevalent today, do you, Dr. Malloy? I think the prevalence is about the same. I don't think that's one of the cancers that's going up in prevalence.
No, I would agree with that. I think it's pretty much the same, and unfortunately, the statistics with it are probably about the same too, as we talked about.
In terms, it's actually not that common of a cancer. It's just that it's a pretty common cancer killer because very few people are ever cured of pancreatic cancer.
What type did Stephen Jobs have? Now, he had pancreatic cancer, right? But he had a different type.
I thought it was islet cell.
I'm not sure.
One of those small cells.
Yeah.
Okay.
Yeah, he did not have adenocarcinoma. He did
didn't
not have the common type. He had a neuroendocrine type of pancreatic cancer,
That's it.
which is a less common, less deadly type.
Right. Okay. Thank you. Dr. Malloy, a caller from Duluth, wants to know, can you get heart attack symptoms from eating MSG? Or how does MSG make a person feel?
Well, that's a very interesting question. I don't, I can't imagine a scenario where MSG ingestion would necessarily, unless it was part of an allergic reaction, but as far as causing the cardiovascular issues, the blockages, et cetera, that I don't think there's any basis for that.
Okay. So again, you'd have to make sure that it's not your heart. If you're having
Right.
heart-like symptoms, you can't blame everything on your abdomen.
Absolutely.
Yeah. Dr. McKee, are gallstones inherited?
The tendency to have gallstones runs in families. I mean, certainly if your mother had gallstones, your father had gallstones, you're more likely to have gallstones than the person on the street who doesn't have family history. So yes, I mean, it's not a certainty. If your parents had them, you won't necessarily get them, but the risk is higher.
Sure, thank you. We just have a couple of minutes left. Dr. Nelson, a caller wanting to know, at what point symptoms-wise should you have your gallbladder removed?
Well, usually if you just have 1 or 2 attacks and you know it's from your gallbladder, you should have it out, because the studies show that 25% of people who have typical gallbladder symptoms, and you are attributing the symptoms to the gallbladder, which is important. As a surgeon, I see a lot of people with all kinds of pain, and my first priority is to attribute their symptoms to the gallbladder so that they get better when they take the gallbladder out. So if you have 1 or 2 attacks, you should have it out, because 25% of people will go on to some type of emergency situation where they have an attack that doesn't get better. They get a common bile duct stone, a stone in the main bile ducts, and these guys have to go in and fish them out. Or they can get gallstone pancreatitis. So you want to avoid that. Otherwise, you just keep having symptoms, and it usually happens when you have to go to a wedding or a party or something, the most inopportune times.
Sure, and it's not just that you have those symptoms. There are serious complications that can occur if you just let it go on, on and on. Dr. Malloy, the question here, a caller from Evelyn, what should you do if you're choking at home and are by yourself?
Well, that's another good question. I suppose you could attempt to do the Heimlich, but 911's your quickest solution there.
Would be good, yeah. We're almost out of time here, and I would like to say we've had a couple of really good questions regarding lower GI problems, diverticulitis, hemorrhoids, surgeries like that. And I think that that is our topic next week, actually. So we didn't get to those questions tonight, but please feel free to call next week with those. I'd like to thank our panelists, Dr. Thomas Malloy, Dr. Daniel McKee, and Dr. Tom Nelson, and our medical students, Stephen Paulquist, Shrikar Rajgopal, and Ben Stranghelli. Please join Dr. Ray Christensen next week for a program, as I mentioned, on lower GI problems, when his panelists will be Dr. Bradley Irwin, Dr. Adi Lakari, and Dr. Ayan Raji. Thank you for watching, and good night.